Welcome back to the podcast, Angie. I'm so excited to have you on for the second time. I always considered you to be one of my mentors. Anytime that I have a mile question, a business question, I'm like, what would Angie do? Let me reach out and ask her. So
Oh,
thank you for taking the time to come out and chat with me. I really appreciate it.
I am super excited to be here again, Brittany. So thanks so much for having me back.
Absolutely. And, we kind of already know what we're going to talk about today because I reached out to you. I don't even know if it was a few weeks ago, a month ago. I always love your posts when you come out with your sassy
Thank
posts and
you.
when they're against the norm. And, you came out with this post about how you feel jaw posture being more important than tongue posture. And it
Yeah,
kind of just lit my soul because I feel like more often than not, I'm constantly saying to my patients, look, we're missing the big picture here. I need you to stop focusing so much on your tongue because you're missing the whole idea here. If
yeah,
your jaw is open, if your lips are parted, forget about where your tongue is because we already know where it's going to be.
exactly.
So let's kind of dive into that. And even though, it might be an unpopular opinion, I think it needs to become a more popular opinion. But if you want to kind of talk more about that and how you really need to look at it that way in order to have true success with your patients.
Yeah, absolutely. And, just to give a little bit of context to my thought process, when I say stuff, when I have my sassy post where I'm wearing my sassy pants and I feel like I say something that needs to be heard, my intention is to bring awareness to other perspectives in myofunctional therapy. We are a multidisciplinary field and we all have different viewpoints and different reasons for treating orofacial myofunctional disorders. And because my background is dental hygiene, I love nerding out over the dental science portion of it. You know that you've taken my About Face course,
Mhm.
so really rolling my sleeves up and digging into the literature has always been one of my favorite things to do. And I really started to notice, I've been in this field for about 12 years now. And when I started, there was nothing out there. I mean, you couldn't even find podcasts, you couldn't find books, you couldn't find before and after pictures. So much of what is happening in our field has really happened in probably the last 8 to 10 years or so, and even more recent. And that's awesome. That's an awesome, awesome thing. But the problem is, like with any renaissance of any field, is we start discovering new things and we start exploring new things, and it's exciting. And then we start to repeat a lot of those ideas. And before you know it, things get repeated that aren't really backed in science. And
Mhm.
a widely repeated idea is not the same as a fact.
Mhm.
And so, obviously in our field, we're all kind of conditioned to think about tongue posture shaping the palate. The tongue has to be in the palate. That tongue puts light, constant pressure on the upper jawbone as it grows. So we get good basal bone growth at that midline, maxillary suture. And that's a beautiful thing. And that absolutely does happen. So, when I say that jaw posture is more important than tongue posture, I'm not downplaying the importance of the tongue resting in the palate because in an ideal world, we would all have our tongues resting in the roof of the mouth. But there are so many other things that influence craniofacial growth. And I think that one of the flaws that we have currently in our field is that we hyper focus on
Mhm.
this one thing.
Mhm.
And it's all about tongue posture, tongue posture, tongue posture. And I feel like the recent awareness and growth of tongue tie issues has almost served to make that problem worse because now all we focus on is a tie, tie, tie. Is it ankyloglossia? Is it tethered? Is it a low resting tongue posture because of a tie? And we have forgotten that tongue ties are only one small part of
Mhm.
that greater umbrella of orofacial myofunctional disorders. And orofacial myofunctional disorders are not just low tongue posture. They're incorrect jaw posture. They're, mouth breathing. They are increased dental freeway space. They're open lips. They're incompetent lips. So all of this has kind of gotten, I don't want to really say out of hand, but I feel like the more we've learned,
Mhm.
the less we've focused on the big picture as a whole, and the more we've kind of hyper focused on a couple of things. So, that is kind of the perspective that I'm coming from is when I say things that I say, I'm not just shooting from the hip and spouting opinions. I am taking years of research plus years of clinical experience plus years of, I do a lot of missions in foreign countries, dental missions, and I have seen mouths and tongues and teeth in different countries. And I'm looking at them and I'm going, wait a minute. The things that we're saying in my functional therapy about tongue tie always leading to a high narrow palate. And so we always have to, do this, this, and this in order to remedy that. Or, the fact that like if you're tongue tied, you're never going to have great arch development. That's not true in other countries. And boy, I mean, we could spend a whole podcast just talking about all of the reasons for that, the way that people live, the way that people move, the way that people, I mean, I was just in Japan recently. They don't have furniture. You sit on the floor or you squat, And so I saw lots of older people early in the morning out in their gardens, squatting down and tending to their gardens. And, you go in the house and you don't plop on the couch. You sit Indian style on the floor, or I'm sorry, crisscross applesauce. I should use a better term. But there are things that we do, and it's beyond the food that we eat, and it's even beyond the way that we, how long we nurse our babies. All of those things do play into it, but just movement of our bodies in general has so much of an impact on the growth of our head and our face and our jaws. So it's so much broader, I think, than, oh, tongue tie leads to high narrow palate or low resting tongue posture. So I really wanted to look at jaw growth and how jaws really truly grow. So, absolutely tongue posture is an important part of it, but the way that we breathe, the way that we move, the things that we eat all have just as much of an impact, I think, on growth of the maxilla than just the tongue posture itself. So that's kind of the perspective, that I'm coming from. So as I dug in, the thing that really kind of started this was about 5 years ago. I was in Zambia, Africa, and I was doing a dental mission, but we had used the students from the dental school as our interpreters, and we were also supposed to be teaching them some techniques at the same time. And so I happened to be there with Dr. Lori Cockley, and I'm not sure if you know who she is, but she's a phenomenal dentist here in East Berlin, Pennsylvania. She is kind of the queen of infant tongue ties. She and I were doing this years before people even knew what a tongue tie was. And how it impacted growth and development. And so, she's been around the block and she's got amazing experience. And so she and I were on this dental mission in Africa, and we did some lectures at the dental school. We were talking to the students just about craniofacial growth. I was talking about myofunctional therapy. She was talking about tongue tie releases and how all of this plays together. And obviously we start looking in mouths of the dental students. And, after I gave this, like what I thought was a great lecture about how if you're tongue tied, then it's going to lead to a high narrow palate. I saw this dental student and he had all 32 teeth in the widest, most beautiful arch I have ever seen in my entire life. And he was tied to the tip of his tongue.
I feel
So,
like when patients, the more they're tied, the better arch, like they end up having better arch development than compared to somebody that might only be like a grade 2 or something.
yes, because if you keep your mouth shut, you still get growth in that lateral and that forward direction when your teeth are in close proximity. It's not like the tongue is like pressing up against the roof of the mouth. There is that light constant pressure there, but that's kind of counterbalanced by the flow of air through the nose, right? Helping to push down. So even in our infants, when they're nursing and those tongues are up, that airflow through the nose is pushing down. And that really has a big influence on that transverse width of the upper jaw. But, I started seeing more of these people where I'm going, okay, I'm looking at these people. What I've been conditioned to think is that if you're that tongue tied, you're going to have a high narrow palate and it's going to really affect craniofacial growth. Beautiful transverse width, beautiful AP growth, all 32 teeth, no issues with function, no issues with speech. And I'm scratching my head going, what the heck? Like,
this isn't supposed to be.
yeah, everything I thought about this is not true for this patient. And then I started to see a couple of kids, in my own practice who were extended breastfeeders and were significantly tied and had really good arch development. And I started seeing all these situations, and each of them were a little bit different. There wasn't one thing that I could say, this was the thing that helped them grow favorably. So I really believe that it's multifactorial, but the one thing that they did all have in common had nothing to do with their tongues. It had everything to do with their jaw position.
Mhm.
So, as we dig into the dental literature, it's easy for somebody from the dental field to understand the concept of supra-eruption. But I started going, why is it that some faces grow into that beautiful mesocephalic, equal thirds, five eyes wide, like everything that we know about good symmetry. And then other people, even without tongue ties, have some, that long dolichocephalic face or the mid-face deficiency or, a myriad of all these issues that we see. So I started looking at some research papers on just super eruption and craniofacial growth. And it's interesting, you have to kind of dig a little bit to be able to find some stuff. But I actually found some literature, talking about like TMJ function with people who were dolichocephalic. So anybody with that high, like steep mandibular plane, that high angled jaw, they have more of a tendency for periodontal issues. They have more of a tendency for temporomandibular joint issues. And those are a lot of the people that have myofunctional issues as well because their jaws were open. So let's talk about the science a little bit. I know that you understand this concept, and I think that some of your listeners understand this concept if they're coming from a dental background, but I'm going to kind of go through the basics
Yeah, totally.
just for everybody. But I'm going to try to simplify it as much as possible because that's my favorite thing to say it in layman's terms.
I
But
love that. You're
so
born
I
to have that last name.
was exactly. Oh my. So here's what happens when we have increased dental freeway space. So, for anybody who's listening who isn't in the myofunctional world and wants to know what that is, when we look at the proximity of our teeth to each other, our top to our bottom teeth, teeth should not be touching all the time. They should not be closed completely. We should have a cushion of space. Typically, most of the literature that I read says about 2 to 3 millimeters of freeway space between the teeth. Dental freeway space is incredibly important. And if we keep our jaws in that correct dental freeway space, then our tongue really has no other option but to put some pressure on that alveolar ridge and help it grow to the right size and shape. Even if it's not 100% perfect, it still gives a significant, positive influence on that transverse and that AP growth of the upper jaw. So, freeway space is always an important topic in dentistry. We talk about it a lot. We talk about it when we're, prepping crowns. We talk about it when we're, looking at putting restorations in there. We talk about it when we are making any type of splint or appliance for the mouth. We really need to look at a patient's freeway space. And the cool thing about teeth is, they have this proprioception that they know when to stop erupting into the mouth. So as teeth from the top drift and teeth from the bottom come up, when they get to that appropriate freeway space of about 2 to 3 millimeters, the body says, cool here, and they stop erupting into the mouth. And that's really, really important. So what happens if you have an increased dental freeway space, if your jaws are hinged open? Now we have way more than 2 to 3 millimeters of space at the level of the molars. What are the teeth naturally going to do? They're going to continue to erupt toward each other. Now, it's not just the teeth that erupt, the alveolar bone is going to follow. And it's going to grow right along with the teeth. So now we have this vertical drift of the top teeth down, the bottom teeth up, and they're not going to be happy until they are in that 2 to 3 millimeters of proximity to each other. So, what does that mean if we have a child who their mouth is open all the time? And it's not just a tongue tie issue. This happens most likely because of airway issues, tonsils, adenoids, allergies. It can be a tongue tie related thing, but it's often a nasal airway obstruction or a pharyngeal airway obstruction. So, what happens when we have that child in that position with the jaw hinged open all the time is they get that vertical drift. They get teeth supra erupting or over erupting toward each other in the back. And then all of a sudden they end up with this steep jaw angle. They've got what we call in dentistry as a hyperdivergent profile or a dolichocephalic face. They grow into that long, narrow, skinny person. They may have an anterior open bite where now the front teeth are not able to kind of overlap appropriately now that the back teeth have over erupted. So this is a tough situation because these kids, as they grow into this profile, have a tendency to have more airway issues, right? It's that snowball because now we're narrowing everything. As we grow into that hyperdivergent profile, the alveolar bone around the teeth is going to be thinner and thinner. So we have less bone support around those teeth. It's going to change the position of the condyle in the fossa. Now we have increased tendency for temporomandibular dysfunction. So it's this whole snowball effect. So, these patients come to us when, as a myofunctional therapist or maybe as an orthodontist, these patients come into us when they're 7, 10, 15, 35, who knows, whatever age they walk into our office, and we see this long, skinny face. And we see this open mouth posture because now the lips are incompetent. They can't meet. We see that steep angle and we go, oh, I bet you they have a tongue tie. What? They might. They might. But I feel like everybody's knee-jerk reaction now is to go,
Yep.
oh, they grew that way because their tongue is tethered to the floor of their mouth.
Mhm.
No, they grew that way because their jaw posture has been incorrect their whole life. Their
Right.
jaw posture may be incorrect and it may be tied into some tethered tissue. But tethering of a tongue will not cause a patient to hang their mouth open.
Mhm.
Not being able to breathe as a
Mhm.
result of that tied tongue is going to make that patient hang their mouth open. Or more likely, not being able to breathe because they've got big walnut sized tonsils or they've got nasal allergies or they've got big adenoids. That's going to cause them to hang their jaws open and grow into that profile. So I feel like everybody has this idea that if your tongue is tethered to the floor of your mouth, that automatically you're gonna like drop your jaw
Yep.
and be a big mouth breather. And it doesn't always happen that way. So, that's pretty much how I look at things now is what can we do to fix the jaw posture? If we need a frenectomy, absolutely, I'm 100% in favor of doing it when it's needed. And I've said this before. I don't know if you and I have had this conversation, but I feel like, over a decade into this field, and I am less sure when I see a new patient and I do their 2-hour comprehensive exam of whether or not they're going to need a frenectomy. I rarely tell somebody day one, oh, yeah, that's going to need to happen, unless
Same.
it's like a really frank anterior
Right.
restriction, because even some of those things that we call posterior tongue ties, which man, I hate that term. It's submucosal. There's a submucosal restriction.
Mhm.
So we like to refer to them as submucosal restrictions or submucosal ties in our office. But if somebody has that submucosal restriction where the back of the tongue is obviously not moving well,
Mhm.
and they have that Mallampati score of like 3 or 4, you can tell it's blocking the airway. They've got all the symptoms. That's not necessarily meaning that there's a true restriction back there. It just means that they have poor range of motion, which could come from a variety of things. So I like to really understand what's causing that poor tongue range of motion first before we decide on a treatment plan. And sometimes you can't know that until you go through, 6 or 8 weeks and sometimes
Yeah.
more of therapy to go, okay, now we're going to remeasure, I'm going to refeel, and you've done the body work, you've done this, we're still having trouble. It's time to go do it. Or, oh my
Yep.
goodness, look at the improvement in range of motion.
Mhm.
We're
Mhm.
good. It wasn't a tongue tie at all. It was just poor mobility
Mhm.
because of, these other factors.
I couldn't agree
So,
with you more. I don't think that anybody should be recommending a tongue tie release during their evaluation. Unless, like,
yeah.
to your point, if
Unless it's
it's,
off, yeah.
yeah, but like, yes, we're obviously doing a functional assessment during that evaluation, but like you're continuing that functional assessment through every single
Oh,
session. Like
yes.
that's where you really start to understand, like, all right, that iffy tongue tie that might be there, might not be there. You know what? It's totally serving as a roadblock. Like we can't
Yeah,
progress any farther. I
100%.
totally agree with that. And I say that to families all the time. I'm like, look, I'm telling you this because I don't want to get 2 months into therapy and then be like, oh, hey, there's a restriction here. Never told you
Yep,
about it. So
yep.
I'm just going to say, look, I don't know what's going to happen. We need to
Yes,
do myofunctional therapy anyways. So let's start. Let's reassess. And you know what? Maybe we don't need to do anything because if functionally they're able to do everything that I need them to, there's no reason to
we're good to go.
recommend a procedure because it's not a tongue tie.
Yeah. It's the beauty of being in practice for a little while and just gaining confidence as a therapist is I'm 100% okay
Mhm.
with not knowing the answer to something.
Mhm.
I'm 100% okay with being wrong about something.
Mhm.
I may look at a patient and I'm like, yeah, I don't think that you're going to need it. When we
Yep.
get 10 sessions in and I'm like, so I'm sorry, but like, I think that, and, or, the opposite, like where I go, oh, you were definitely gonna like, we're going to be talking about this in the future. And I'm pleasantly surprised. And it doesn't like, I don't understand. I think there's some people who feel like we're supposed to have all the answers and have it all together. And I feel like it's better in many ways to just be humble enough to say, I don't know. I just started a
Mhm.
patient yesterday who has some weird symptoms going on. Um, there's an obvious orofacial myofunctional disorder, which is why I feel comfortable taking this patient on because I can treat the orofacial myofunctional disorder. But some of her other symptoms are not from an orofacial myofunctional disorder. And so I think part of my job is getting her to the right people and kind of helping, guide her along the path. But I'm comfortable saying, I don't know how much this is going to help you. Can we improve things? Absolutely. Is it
Mhm.
going to fix all of your problems? Probably not. Or every once in a while, I have patients where I'm like, I'm not sure how much benefit we're going to get out of this. If you would like to try, I'm 100% willing to help you. Um, I don't feel like I need to sell myself as the fixer of all things.
Because it's not like
Because
myofunctional therapy is not the end all be all. It's not the
no,
answer. It's an adjunct to whatever
yes,
else, whatever other providers need to
yes.
get them to.
And that's another thing that I think that we say a lot is like, oh, this is the root cause. Like your tongue posture is the root cause. Not always,
Mhm.
even breathing issues. Like, why are you breathing that way? There's other root causes to why we have breathing dysfunction. So, I feel like I don't want to say that we're all getting a little too big for our britches, but I feel like sometimes we're getting a little too big for our britches. Like my functional therapy, I love it. I love this field,
Mhm.
but it is not the solution for every single problem that we see out there. And I feel like we have lost the art of the differential diagnosis
Mhm.
and we have lost the skill of humility,
Mhm. And I
right?
think one of the things, and I know I struggled with this in the beginning, and I think a lot of RDHs that practice myo do because, dental hygienists tend to have a very like type A personality. It goes like this. It is in this order every time. I
Yes.
scale the teeth in a certain way. I do not veer from my norm. I can do this
Yes.
with my eyes closed. And that is, with our students in our Team Myo course, that's one of they're looking for this like cookbook that they can follow. And I'm like, look, you're
Yeah.
not going to get that here.
You're
That's
not going to
not
get it.
how you're going to be able,
Yeah.
there of course are some programs out there that teach more of that. And my first myo course that I ever took was a cookbook recipe. And I found very quickly, like, but wait, my patient
Yeah.
can't do that exercise. What do I
Yeah.
do now?
Yes, exactly. And that's the thing is like we're all type A and
Yep.
everything in, when we're treating perio is black and white. If it's this many millimeters, it's this type of periodontal disease.
Mhm.
If you have this many bleeding points, you're going to categorize it as this. And so we want that cut and dry, do it in
Mhm.
this order. And so I do feel like a lot of hygienists go into this and get a little bit of shell shock because
Yep.
they go, okay, this is all really fascinating. But what happens when you get that patient that you're like, okay, they're not the norm, and you start to
Right.
find that most patients don't fit the norm. And
Mhm.
that's why you have to really know, like, you have to have those critical thinking skills and you have to understand the science behind it because this is an artful application of the science. So
Mhm.
if you don't know the science and you don't know how to look at somebody and go, okay, here's the problem that I see, whether it's, rounding and spreading of the lips, or this patient can't narrow and widen their tongue, or whatever thing it is that you're like, my patient doesn't know how to do this, to
Mhm.
be able to go, okay, what can I do? What are 10 other ways that I could help facilitate that movement rather than just what exercise do I do? Like, that's the
Mhm.
thing. Like when people,
Mhm.
I've removed myself from a lot of online groups for a variety of reasons. But like every time I see a new therapist who's like, well, what exercise would you do for lip incompetence?
Hmm.
I would do a couple of months of like 15 different things
Right, right.
for like certain problems. Like it's not just a here,
And
use this
that
exercise. Like,
what you might have done for one patient for the same
yes.
problem would might look completely different. Their treatment
Yeah.
plans can be completely different. I think
Because
that's
why
the
does that
part
patient,
too.
yeah, why does that patient have lip competence? Do they have that hyperdivergent profile because they had poor jaw posture? Or do they just have a short upper lip because maybe there is some tethering up there? Or maybe because they were a mouth breather and we just need to like,
Mhm.
do some exercises to kind of help, increase a little bit of collagen production up there, get a little bit of a longer philtrum. So there's a million reasons why patients have myofunctional issues. So learning, I think, as hygienist, how to look, figure out what's the reason that this patient is struggling with this, and then have those critical thinking skills to be able to know how to fix it. Because when you
Yep.
know the sequence and you know like how the muscles develop, you can
Mhm.
go, oh, I recognize the step that I skipped that I shouldn't have skipped. And then
Mhm.
you can go back there and get success with that patient.
And I think it comes just from experience. Like you have to, I
Yeah.
always say to, hygienists or any new myotherapist, like you need to dive in, like you need to start
Yes.
with patients because you can ask somebody all these hypothetical questions or
Mhm.
look at case studies of a particular case, but the person sitting in front of you is going to be completely different. They're going to
Yeah.
present differently. So we have
Yeah.
to definitely use those critical thinking skills. And that's nerve wracking, of course, because again,
It
you're
is.
a hygienist for however long 10, 20, 30 years, and you're very comfortable. And now you have to break out of that. But it's also
Yeah.
really cool and fun. Like that was, it almost, it kind of lights you back up. Like it gives
Yeah.
you, it's just exciting to do something new every single day.
Oh, I live for difficult cases. They
Yes.
excite me. The
Mhm.
ones that I have to go, what in the world am I going to do with this? And sit down and research and figure it out.
Yep.
That's what excites me because, I mean, truth be told, people probably don't want to hear me say this, but if you have easy cases all the time, it does start to feel kind of repetitive, like hygiene, like clinical hygiene.
Yes.
And I'm like,
Yes.
oh, I'm doing the same exercises with the same patients, and it's kind of getting
Mhm.
boring. So,
Mhm.
luckily I have a tendency to attract like very complex cases, which
Yep.
that's my jam. So,
Yep.
I love those because it is a challenge for my aging brain.
Yep.
Have to figure out what are we going to do and who am I going to pull in for this, team approach for every
Mhm.
single patient, and it looks different for every single person because they're
Oh
all
my God,
unique and individual.
1000%.
Yeah.
Absolutely. And you touched on this a little bit before, and I actually want to talk about this today. Finding that root cause of the mouth breathing. And I feel like there are so many patients out there with unmanaged allergies.
Oh,
And like it's just like how we can't be successful if we do
yes.
not figure out a way to manage this and stay on
Yes.
top of it. Sometimes then I find patients manage their allergies and then they're like, oh, I'm feeling better. So let me stop. And it's like,
Uh-huh.
it's perpetual cycle. And it's like, but you don't understand. Literally, you have to be able to breathe through your nose or like
Yes.
we literally can't be successful. So talk if you can a little bit about I don't know if you have like protocols in your office, like seeing ENT, seeing allergists. What do you do if they don't follow through with that? How do you
Yeah.
help patients kind of stay on top of their allergies? Just talk a little bit about that.
Yeah, and that's so tough. Like I live in South Central Pennsylvania, and I know that like in every state we're always like, we have the worst allergies ever, but I feel like we really have the worst allergies here. Right now, I'm even suffering. It's like, the corn is like, the corn pollen is getting to me right
Yep.
now. It's all being cut right now, which is good. So hopefully by next week I'll be able to breathe again. But, it's a real problem for so many of our patients. So I am very insistent on we take care of that nasal airway problem first and foremost before I start somebody. If I have somebody that comes in who has like they can't even breathe through either nostril, I am never, ever, ever going to start them in a program with me. Why would I?
Mhm.
If you do 5 minutes of exercises a couple of times a day,
Mhm.
but the other, 23 hours and 45 minutes, you are sitting there with your mouth hanging open, we are not going to see results.
Mhm.
So, so much of it depends on the age of the patient,
Mhm.
what the issues are that are kind of contributing, because, often with people with nasal airway issues, the nasal allergies, if they're older, now they've grown into that narrow jaw. So sometimes I'll get um, the orthodontist involved a little bit sooner rather than later. I often have an allergist. I have a dual specialist, allergist and ENT
Oh, that's
close by.
lovely.
And I know, right? That's like I've got two people who are both ortho and perio that I work with. And I have one doctor who's ENT and allergist, which is awesome because, like nothing feels worse than when you're telling your patient to go to like five different places for, oh, I want you to do this, 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 and this. And then they get some burnout. So
Yeah.
we try to keep it as concise as possible. So I have a really great ENT that I work with who's also an allergist. He does a phenomenal job of looking at structure and remedying structure, but also testing for allergies and helping these kids or adults, whether it's allergy shots for a while or the right medication or changes, that they need to make in their environment.
Mhm.
So it's hard, it's hard. But that you said something really important. It's the fact that like once you feel better and you're like, oh, I'm good, I can breathe like, 60% today, people stop taking their medication. And that's not the way that it should go. The
Mhm.
other hard thing is when we get families who really want to take a more holistic approach to managing the airway. And I'm a mom. I 100%
Mhm.
get that. I don't want to
Mhm.
give my own children medications unnecessarily.
Of course.
And so, we try to work with those families. I've got some great providers. I've got a homeopathic doctor that I make some referrals to. I've got a lot of great functional med doctors. We have nutritionists that we can refer to. So there's so many different ways to approach it. But, and here's my big but. That sounded really funny when I said it, didn't it? Not my big butt, but here's a big butt that I'm going to put in this sentence. We get to a certain point where I'm happy to try as many holistic and natural ways as we can to help with the inflammation, to help with the allergic reaction. But at some point, if you have a child that can't breathe, you have to make tough decisions sometimes. And it may not be what you wanted to go and have those tonsils or adenoids removed. But my goodness, are you going to have benefits, positive benefits
Mhm.
from that in the future? And that is something that, we try to help parents understand. We have a baby and we think that everything's going to be perfect and it's going to be beautiful and we're going to feed them all organic food and we're going to nurse them forever and they're going to go to Montessori and they're going to and then life happens and you
Right.
realize that like parenting is hard, and part of parenting is the fact that sometimes you have to make choices that you don't want to.
Mhm.
And sometimes that choice is tonsil or adenoid removal. I just saw a sweet mama yesterday, Dr. Beth and myself. Dr. Beth is our speech pathologist who does feeding therapy and lactation in our office. So we, did a combined consultation with a sweet family yesterday with, two sweet little girls whose tonsils, like one of them, the tonsils were touching. One could not breathe through her nose at all. And they had gone to the ENT like we had recommended, which was awesome. And the ENT was recommending surgery for both girls. And the mom just needed some reassurance that this was the right path. And so it was 100% the right path for those little girls. So, we don't want to have to put kids through things,
Of course.
but if your child can't breathe, your child can't grow well, your child can't thrive, your child's brain can't develop the way that it needs to. And so the means to an end is what really matters. This is going to help her children grow and flourish and be healthy for a lifetime. That one surgery that we're going to have. So,
Yeah. And I think, a lot of families are like, well, we don't want to remove their immunity,
right,
their first
right.
line of defense. But, then you have to think how many times your child's been sick over the last year. Like
Yeah.
their
Oh
immune
yeah.
system ain't working too well with those
Right.
gigantic tonsils in there.
Exactly. Or how about every time you put an antibiotic into that child's system, what does that do to their gut health? And how long
Right.
does it take for their gut health
But
to,
kind of like
to
bringing it
improve?
back to what, you said in the beginning, like we're programmed to think certain things. So like
Yeah.
we're taught that our tonsils and adenoids need to be in there. They need to be in there. Our
Yes.
immune system is going to be shot. but then what about what negative effects that these enlarged tonsils and adenoids are then causing on the body? They're not sleeping, they're
Yeah,
not breathing. How's their
exactly.
immune system ever supposed to be in favor of helping the body? You know what I
Yeah,
mean? And
absolutely.
but just like you said, explaining it to parents. They don't want to make the wrong decision. They want to do what's best for their child. And I think I always kind of say like myofunctional therapists are kind of like the quarterback of the team because we see
Yes.
them the most, kind of the same way that we are as hygienists, like the doctor leaves the room and the patient's like, so what did he say? What do you think I
Yeah.
should do? Can you explain that to me a little bit more? We're
Yes.
kind of the same way as myotherapists. They come back from their ENT and they're like, okay, so this is what he said. What do you think? Or they talk to the sleep physician, they get the sleep study
Yeah.
results, they come back and they're like, okay, did you see it? Like, what do you think? And it's really cool, to definitely be in that part of everybody's journey and just that education and that talking with families. Like they
Yes.
just need to hear it. They need to hear that they're doing the right thing for their child.
Well, they need somebody to listen. That's the advantage of like you and I both have our own business. And so, even though we're incredibly busy, I know for myself, and I'm sure this is true for you too, that you feel like you can spend the time that you need to
Mm-hmm.
listening to these families. And sometimes that matters more than anything else because they've been
Mm-hmm.
blown off by so many different providers. They are
Mm-hmm.
at their wits' end, they're exhausted.
Yep.
It's hard when you have a child who's not thriving and not sleeping or not eating right. And, so just having somebody listen to them
Yep.
is such an important thing. So,
Absolutely.
yeah, it's an
Absolutely.
awesome role to be in. We have the
Absolutely.
best job in the world, Brittany.
We do. We do. All right, let's see. What's my next question? So I feel like this is something that comes up a lot in Facebook groups, and question Q&As and stuff. The idea of the right timing of myofunctional therapy. Is there
Ah,
a time to do it pre-expansion? Can we phase treatment where we do some pre-expansion? Should we always wait post-expansion? Providers even feel very differently about this, like expansion
yeah.
providers. So share a little bit on your thoughts and opinions on that.
Yeah, so I feel like there's no one right answer because again, we're looking at the individual patient.
Mhm.
So a lot of it's going to depend too on what resources that therapists have available to them in their area.
Mhm.
I am fortunate that I've got a lot of really great connections with a lot of really great providers, and we have some, incredibly well-known early expansion providers here in Pennsylvania. So if we see a young child who has severe airway issues, we've talked to the ENT, we are trying to control things, but they still can't breathe well. Most
Mhm.
recent research is showing that, we can get some resolution with tonsils and adenoids that are enlarged with good skeletal expansion.
Mhm.
So if I look at that child and I'm like, okay, we have a very obvious structural problem with the jaws. We've done all the things that we need to with the ENT and the allergist, but they're still struggling.
Mhm.
Then let's expand them.
Mhm.
Let's get in there, get them caught back up on growth. I don't like
Mhm.
to wait any longer than we absolutely have to for expansion because we know that the older they get, the
Mhm.
closer they get to puberty, the harder it is to really get good skeletal expansion. You can tip teeth all day long, and that's great if you just need a little bit of tongue room. But, some of these appliances that we sing the praises of in myofunctional therapy are really not good for our periodontal health if they're,
Mhm.
especially when they're in the wrong hands. So if a child is old enough to tolerate expansion,
Mhm.
and we're still struggling with breathing, then I'll often send them for the expansion first.
Mhm.
If I have a child who, like, okay, we've got decent nasal patency, tonsils are okay, they're a little bit on the young side for traditional RPE at like, age 7 or whatever, but we've got some myofunctional issues, but cognitively that child is aware enough that we can be successful with therapy. We might start therapy on, a younger child, either like late preschool or early elementary school, and have good success. Obviously, as kids get older, they're a lot more compliant with the exercises. A lot of it has to do too with, is it a boy who's like really restless and like needs to be active? Like, are they going to be able to sit and do the exercises? Is it a girl who is maybe 10 and you can already tell that she's a lot closer to puberty than a lot of her peers. So I'm going to get her to the orthodontist first. There's so many different factors that kind of play into it. And I don't think that there's a right or wrong way to do it. Other than the fact that if somebody can't breathe, I'm not going to treat them.
Right.
Like we're going to do other things first.
Right.
So
And what about when they have an RPE in? What is your take on doing myo with an RPE in?
yeah, I rarely ever do therapy, active therapy,
Mhm.
while they have that appliance in because it's competing for space. That's exactly where we want the tongue to rest. And even with the ones that don't have acrylic and they just have the jack screw in the middle, it's
Yep.
still right smack dab in the middle of the palate. And honestly, most of my providers, they don't keep that appliance in there for very long. So that child might be, gone for 6 months and then they'll be
Right.
back. So it's
Right.
not like mission critical that we don't do therapy during that time
Exactly.
because we know that 6 months later they're going to be back in my office and we're going to be able to really help. And sometimes I do split treatment. Sometimes we have a child who for whatever reason the orthodontist is like, I want another 6 months of growth before I'm
Yep.
comfortable putting an appliance in. I might do my phase 1 of therapy,
Yep.
cut them loose for a little while, let them go get expanded, bring them back, do the second half of treatment. A lot of my adults that are in a MARPE, we'll do it that way. Sometimes we do a little bit of work ahead of time if necessary,
Mhm.
but usually for my adult patients, I prefer that they go get that maxillary skeletal expansion first.
Yep.
And then we're going to bring you back and we're going to address the myofunctional issue and the tie, if there is a tongue tie in there as well. We'll do all of that after. So in a
Right.
perfect world, I would change structure first
Mhm.
and improve function second. But every once in a while, you get those cases where you're like, we got a pretty serious function problem.
Yeah.
And like a gagger, if I have a child who like really has a hyperactive gag to the point where we're never going to successfully get an appliance in there, then I'm going to work with them for a little bit. And
Yep.
then I'm going to send them for expansion. And then they can come back and we can kind of finish up toward the
Yes,
end.
I totally agree too. I don't ever really do treatment while they're in that expander. And I think too, like, really, no matter who you are, people get tired of doing their myofunctional therapy. Like, they don't want to be in
Yeah,
treatment for years and years.
forever.
And it's expensive. And, these patients are paying out of pocket. So I always explain to them,
Yeah.
like, I want to work with you when we're going to have optimal results. And
Yeah.
that's going to be once that expander's out. I might too do some like phase 1 stuff, prior
Yeah.
to expansion. And I get it. Like, I know there's myofunctional therapists out there that do work with patients while they're in expansion. And I'm not saying that that's wrong. I just feel that if I were to do that, it would then extend my treatment with the patient.
Yeah.
And I just personally don't think that that's necessary. But
Yeah,
that's just,
you're kind of fighting an uphill battle. Like we want them to stay motivated. We want them to see results. So
right.
yeah, you can work with facial muscles, you can work with lips a little bit. So I might see somebody periodically, but I'm not going to have
Right.
them in intensive therapy during that time.
Now, what about tongue tie releases before or after expansion?
After, if we can.
Yeah, that's how I
Yeah,
feel too.
after, because where's that tongue going to live?
Hmm.
And some people are like, oh, but it's going to help the jaw grow.
Hmm.
Not in that 12-year-old kid, it's not.
Right.
Like maybe not even in that 8-year-old kid.
Right.
In a
Right.
3-year-old maybe, but not like I think people. And again, here I'm going to go off on one of my tangents. I'm going to try to keep this short and sweet. I'm going to try not to put my sassy pants on, but some of the other misinformation that is prevalent in our field is about expansion and what it is and what appliances truly give you skeletal expansion and what appliances just don't, no matter how good their marketing is and how many pictures you see of arches that do indeed look wider. People don't understand that there's different ways to remodel bone. We're bending that bone, but we're not truly getting a good
Hmm.
skeletal change. And so, we have a much shorter window for really influencing craniofacial growth than what we think that we do. And so, some of these appliances that a lot of therapists tend to be on the bandwagon for, I'm like, that is the last thing that I would advocate for my patient putting in their mouth. But oh boy, I don't want to ruffle too many feathers today. So that's another topic for
For
another day.
another, that could be a whole separate podcast.
Totally could be a whole separate podcast.
Okay, well, I have two more questions and then we
Sure.
can wrap up. So let's see. I'm sure you get this question a lot too from, new myofunctional therapists going out and trying to network. Like,
Yeah.
let's say they're trying to network with a orthodontist. Um, what would be like the main point that you would kind of try to drive home with them for them to understand the importance of your work in their treatment?
Yeah, that's a good question. I think it all comes back to the buzz phrase tongue thrust. Because still,
Mm.
no matter how
Drives
much
me
good
crazy.
information I know has come out, we still have people who say they have a tongue thrust. Their bite opened because they have a tongue thrust. Their teeth are moving because they have a tongue thrust. They have this problem because they have a tongue thrust. And so the cool thing about a tongue thrust is it's an easily recognizable symptom of an orofacial myofunctional disorder. But orthodontists are smart enough to know, and if you just kind of give them like the 2 sentence explanation that teeth move by light constant pressure, teeth do not move by heavy intermittent forces. How does orthodontic treatment work? Light constant pressure. So that intermittent thrust of the tongue really has a lot less to do with that patient's occlusion than you think it does. But if you have that low resting tongue posture for whatever reason, if you have those jaws that are open beyond the normal 2 to 3 millimeters of freeway space, if you have lips that are parted, lips should be ideally closed, but literature shows that up to 3 millimeters of space between them is still considered normal. But if you have beyond that, that's when you have a problem. So
Right.
getting an orthodontist to understand that, just blocking a tongue thrust is not
Mhm.
going to fix anything. That's why cribs and rakes ultimately don't work. They don't fix the problem, they change the problem.
Mhm.
So, orthodontists need to understand that we as therapists are their allies in this
Right.
because we're looking at that underlying what's the tongue doing the rest of the time? What are the jaws doing the rest of the time? What are the lips doing the rest of the time? Because that's what makes or breaks a good orthodontic case. Not a tongue thrust, but the rest posture.
Yes. Yes. The amount of times we get referrals for tongue thrust, I'm like, that lunch and learn. It didn't really sink in, did it?
Right. Hey, but you know what? They recognized it and they thought of
Exactly.
you.
And they made a referral.
So,
Exactly.
yeah.
Okay, my last question, and I
Yeah.
don't mean to maybe get your sassy pants on, but I have a feeling that
Oh,
I might
I
a
love
little bit.
wearing them.
I kind of want to talk about kind of just where our field's at, the state of our
Yeah.
field, the tension that is kind of out there between different providers. And, you've been in this for a long time. You're very well known in the field. Our field's lucky to have you. So I kind of want to talk about that because I feel bad for new myofunctional therapists coming out, especially those with an RDH background,
Yeah.
that you almost feel like you have to warn them about it, but you also don't want to like tarnish the field for them from
Taint
the
that I know. Yeah.
yeah.
So, as somebody who's been here for a long time, first of all, it's just disheartening. It's sad to see the state of affairs. Um, but here's what I often like to tell people, especially if it's a new therapist. It's really easy for us to feel attacked
Mhm.
if you are on a lot of these pages in a lot of these groups where people are very vocal and very outspoken. Um, but I tell you what, some of my very best friends in this field are the loveliest, most accepting speech pathologist in the world. So I feel like 5% of the people that are really loud and vocal don't represent the 95% of people who really are working behind the scenes to build bridges and to get along and to collaborate and to work together. And that's what is most important, I think, is that, it's so easy with social media to think that everybody must feel this way. Everybody hates RDHs. Nobody supports us in this field. And let me tell you, there is some serious animosity out there. I've had it directed at me. I've had colleagues who have really struggled. I've seen some really inappropriate, unkind things said about people, and there's no place for that in this field. But I also remind myself that 5% of the people that act that way do not represent the 95% of people who don't feel that way. And that's the sad thing about bullies is when there's a bully, even the people who are supportive of you in different fields, they're scared to speak out because there's repercussions if they
Right.
do. So I feel like, what do I do? What's my role in this? Um, I know that there are some RDHs who have had some really unpleasant encounters with people. And I would just encourage people to just, first of all, don't be dumb. Don't do dumb things that are out of your scope of practice.
Amen.
But I also feel like, for everybody else who is being critical of the RDHs, stop making assumptions. Stop
Mhm.
making assumptions. No one wins when we assume that somebody is doing something that they're not. And, as hygienists, I feel like sometimes we get treated as like second class citizens because they look at the degree that we have and not the level of expertise and education that we have. We have a very condensed degree with
Mhm.
tons of education packed into those 3 years. And we treat medically compromised people every single day in our dental practices. So if you have a medically compromised person that comes to you, that is 100% in our comfort zone and in our scope to see somebody. But you have to be smart about, can they be treated in my role as a myofunctional therapist, can I safely treat them? But I think that there's some assumptions that just because somebody has a certain condition, that we as hygienists should not be treating them, or that somebody is a certain age, that we as hygienists should not be treating them. But our scope of practice involves the oral cavity. We're not
Mhm.
just teeth cleaners. Like
Right.
the oral cavity from birth to death, edentulous patients, come in to see us. They don't have any teeth,
Mhm.
but our job is to look at the oral cavity and look at the health of the oral cavity, talk to them about nutrition, talk to them about hygiene, talk to them about growth and development. These are things that normal hygienists, everyday hygienists who work in clinical practices, who may not know the first thing about myofunctional therapy,
Mhm.
that they do every single day on the front lines. And so
Mhm.
I think that we have not been um, given the full spotlight of the things that we're capable of doing. And then somebody will look at somebody's marketing or read somebody's post, and they make an assumption about what that patient or what that therapist is doing with the patient, and then it blows up into this whole big thing. And it's unfair,
Mhm.
and it is inappropriate. And, in today's day and age, once it's out there on social media, it's like kerosene on the fire. And then the next thing you know, you feel like everybody is against you.
Yep.
And that's when you remind yourself that's not the case. There's
Yep.
loud people against you
Yep.
sometimes, certain following. But, I feel like our role is to do good work, to
Mhm.
treat our patients to the best of our ability, to stand up for what we know is right, but also not stoop to the level of, slandering other professionals, because there is a role for every single one of us in this field. Just because we treat orofacial myofunctional disorders from a different perspective doesn't mean that there's a right and a wrong way. It means
And
that
there's
there's
so much
two
to learn
different ways.
from each other. That's the part that
Absolutely.
like blows my mind. Like, let's learn from each other. Like,
Yeah,
if we're working with an older teen or adult and something happened along their lifespan developmentally, like I want to be able to comprehend that. You know what I mean? So
yes,
me wanting to take a class to learn about like birth to three, like that is for knowledge for me and education purposes
absolutely.
for me to be able to talk with my families. Not to say I'm going to go out and treat it, but I want to
Exactly.
have that knowledge. And I think that that's important and we owe it to our patients to do that. So
Absolutely.
again, like you said, instead of accusing people of taking this information and using it wrongly, like give them like all
Grace.
power to those people that, yeah, that
Yes.
want to learn
Yeah.
more.
Don't make assumptions that we're doing things that we shouldn't be. That quest for knowledge, this is something I don't understand in this field is as a hygienist, for the past like 25 years, I've been taking classes that are to help enhance my knowledge. I've never once sat in a class for endodontics or periodontal surgical procedures or orthodontic treatment and had somebody point their finger at me and be like, you don't belong here because you're going to go do periodontal surgery or you're going to go do that root canal procedure. No, I'm not. Like, as a dental hygienist, I need to understand every facet of dentistry because it's my role to really educate those patients on their upcoming procedure and help learn to recognize things so I can point it out during their exam. So it's so bizarre to me that in all of the years that I have been learning anything and everything about all different fields, that all of a sudden people are looking at us and going, oh, you took that birth to three class? You're treating infants and that's not in your scope of practice. Like, whoa, time out. That's the assumption. That's
Mhm.
when people assume that us getting education on certain topics or
Mhm.
learning things about speech or learning how to recognize certain things so we know when to refer, that is not synonymous with working outside of our scope of practice. That is becoming a much better, well-rounded therapist. And I'm sorry, but I have never seen a hygienist point a finger at somebody in any other field who comes to learn about, expansion techniques and go, you don't belong here. You should not be learning about this because it's not in your scope of practice to treat. I
Exactly.
welcome people to come and learn things that we do in dentistry. I want collaboration. And
Mhm.
the only way that we can really be cohesive in this specialty is if we understand everybody else's perspective, because that helps us know when to refer, right?
Yes.
Like if I recognize when there's a child who has something far beyond just a speech issue that may be involved with an orofacial myofunctional disorder, and I'm going, this kind of reminds me of the discussion about apraxia at that course I was at.
Yep.
I know who to refer them to.
Mhm.
So, education is a good thing. Education is not because we are trying to do things that we have no business doing. And
Mhm.
that's the unfortunate thing is, and again, like there's always that handful of people that do dumb stuff. There's
Of
a
course.
handful of people in every field that
Yep.
do dumb things, but I think it just kind of reinforces the idea that like, oh, see what that person did? They're all guilty of it. And that's just simply not the case. So I do hope that, things will sort of simmer down a little bit. I don't know. I personally have removed myself from so many of the groups because I just don't want to be steeped in that negativity anymore. And it's unfortunate that it has to be that way. But I feel like for new therapists, like keep your chin up. The
Mhm.
only way that you're going to really get good at this field is to roll up your sleeves and do it. Have
Mhm.
a mentor, know who to talk to about cases where if you go, something different might be going on here, that person can say, oh, you're correct. Here's the proper referral. Or, nope, this is normal. This is still in your wheelhouse. Keep going. You've got this, but maybe try this technique instead. I think that if we all come together and we all put our patients first,
Mhm.
then there's going to be no room for negativity. So that's my hope.
Absolutely. Yep. And you couldn't have said it better. Thank you, Angie. Thank you so much for coming on. This episode was phenomenal. I can't wait to get it out. So everybody will be able to listen to it soon. Thanks again for coming
Awesome.
on. And we're definitely going to have you on for a third time because there's literally so much that we can continue
Oh, we could
talking
talk all day, Brittany. We could talk all day.
about.
Thank you so much for having me. I appreciate it.